salon. We have about 20 or so people here in the room. We have a few people connected. And we are very grateful that you are willing to share, especially with our audience from outside of Colombia, some things about yourself, to introduce yourself, and some things about the health system here in Colombia, and how innovation can enter into a system like the Colombian system. If you have some thoughts around that, but if you can educate our guests on the system, we will be very grateful. So thank you so much for your time and your generosity as always.
No, David, thank you, and the university for this invitation. I'm glad to be part of this conference. My idea is to share a brief presentation on Colombia's health system, and then hopefully have some time for discussion. So that's if you agree, my idea for this. I understand, David, please correct me if that we have about 15 minutes for this presentation.
That is correct. That is correct, Camilo.
Perfect. So I'll take in time into account. So again, and thanks, David, and the university for this invite. A little bit about myself and why I'm giving this talk. Currently, I'm a physician and an MBA from Universidad de los Andes. So I'm very glad to be back at the university, virtually or physically, whichever part. I was a project manager at Fundación Santa Fe Bogotá, a big hospital network system here in Colombia. I did some consultancy for a specialized health sector consultancy for some time. And afterwards, I was chief of staff at the Ministry of Health here in Colombia. Currently, I'm corporate and public affairs manager at Boston Scientific for the Andean region. So a little bit on the evolution of Colombian health system. A great discussion in the public arena currently, since we have a new government being starting its term next month. This past 30 years, Colombia has moved from a classic health system to a system that we currently know as regulated competition. We passed in 1983 from 18% of the population being insured in some manner to currently, and last month, 99.7% of the Colombian population being insured and having a payer responsible for their medical bills. We had a national insurance, Instituto de Seguro Social, that's the acronym, a national insurance and small other insurance, mostly private insurance at the time. Currently, we have multiple payers that work, people from the States work more like HMOs than insurance actually, both public, private, and mixed. We'll see it a little bit. Health expenditure was below 5%. Currently, it's above 7%. During the pandemic, it raised a little bit, probably it's going to go down again to around 8% of GDP. We had a very high out-of-pocket expenditure, poorly targeted subsidies, and a disjointed system. And currently we have the lowest after Cuba out-of-pocket expenditure in Latin America, and very high progressivity of our subsidies within the health system. The health sector and the system back in the 90s was in crisis, and the health sector and the system is in crisis today again. We live with a sector in crisis. Basically, the main transformation of the system and how the system works right now, and sorry that some of the slides will have data in Spanish, but I'll translate, is that we moved from a system that subsidized the offering of services and subsidized public hospital networks around the country, to a system that currently subsidizes demand. Through this HMO kind of organization, it gives money to the population through the HMO system to subsidize demand for services, and that's how the system in Colombia operates. We'll see here a comparison. It's 2019 data, but most of our healthcare expenditure currently is public, and only a little bit less than 30% is private. And the out-of-pocket expenditure is lower than 15%, again, the lowest in the region. The roles, and again, some of the slides in Spanish, sorry about that, but the main roles in this regulated competency model that we have in Colombia is this figure that's an EPS that functions as a payer, as an HMO. Our providers that we call in Colombia IPS, to make it really hard and really easy to get confused, but they are the providers. And then we have the users, the patients in a competency model. The philosophy behind that is that users will have freedom of choice, and every Colombian will determine which HMO they want to be a part of, depending on the region of Colombia they live. They choose their payer. The payers, then these HMO organizations, are expert buyers of health technology, and the providers will compete on quality. A very interesting part here in Colombia is that it doesn't matter if providers are public or private, they do compete. So public hospitals compete with private providers and private hospital networks to get contracts with these payers that are expert buyers. And that's really different from most health systems around the world. So then we have four main ways in which we can have financing. Most of the financing, as we saw, is public, and most of the provision of health services is private. So most of what goes on in Colombia is that we have general taxes and specific taxes being financing the health system, and providers of these health services are private. But we have all of the different kinds of financing and provisions within Colombia competing with each other. This top part, the public financing, is what in Colombia we call the general system for social security in healthcare. And this bottom part is what we in Colombia call the additional health plans that we can, as Colombian, have on top of the general system. Really fast, how a little bit the flow of resources and contracting works. In Colombia, the government, through general taxes and specific taxes, mostly to labor, world population gives the government through, again, general taxes and labor taxes, go to an agency in Colombia called the ADRES. This agency gives subsidies to the demand subsidies to the HMO kind of organizations. Remember, they're called EPS, several EPS. Currently, we have 32 EPSs in Colombia, 32 payers, and the population is affiliated to each one of those. These insurers, as expert buyers, contract services with providers, some of them in vertical integration, as an example in EPSB with IPS2, in which they are the same company, or different companies. So we have big networks, integrated networks, similar to what Kaiser Permanente model in California could be in the red example. And then we have independent insurers and independent providers, as well as is characterized here. This flow is a little bit much more complex than what I showed you, but the idea is not to have a complex presentation right now. The flow of resources depends a lot on the type of services that will be provided. We have some special regimes that function differently, for example, for the armed forces or the biggest oil company in Colombia, and it's a little bit more complex, but again, that's the idea here, is to give you a big overview. We have a very diverse country. These are all the departamentos or states within the country, and this is just an example of the mortality rate because of respiratory infections in under 5-year-olds, and the profound differences that we have within the country. So the health system needs to address very different regions within a very diverse country, and that's what I wanted to show as an example with one indicator. We have a big challenge with healthcare personnel. This is a comparison with similar countries like Ecuador, Chile, or Mexico, and see, for example, North America in terms of medical professionals and specifically nurses by 10,000 population. We have a big challenge in the number of medical personnel, and as we saw in the last slide, the distribution within the country of this personnel. We talked about it in the start, is just to show that since 1993 and 2021, currently at 99.7% of the population is affiliated to a payer. So there's no one in Colombia went bankrupt because they had to pay for services provided, for example, during the pandemic because of COVID. That didn't happen in Colombia. We have a very strong social protection in health. And it's estimated that during the last 8 years, around 20% of the people that went out of poverty before the pandemic, it was because of the social protection of the health system in Colombia. The differences that we saw in different regions in Colombia could be attributed again to different EPSs. So there's diversity among these 32 actors. And I'll give you here an example. These two regimens, contributing regimen, people that can contribute to the system, and subsidized, people that cannot and don't have cannot afford to contribute to the system. And I'll give you an example here of the time it takes to assign a medical visit, a general physician medical visit, and it can be a difference between, in average in this HMO, almost 10 days to 2 or almost immediately in another HMO. So there's again differences, and others that could be really important. The time to this first one is the time from the diagnosis of a breast cancer to the start of treatment, and it could go to 80 days in one on average to 43. So difference in quality of the services that are received around the country are not based only on the region, on the country, but on the actors, in this case, the payers of the system. And to sum up, and again, a really high overview of the system, what we foresee in public policy in the near future in terms of supply, and this all has a relation with how innovation can be accomplished, or how innovation can help us in all of these areas. In supply, after a strengthening pharmaceutical policy, not in just only in pharma, but in medical devices as well, more price control and maximum budgets to a constrained system. All health systems, not only Colombia, but around the world, has these constraints on their budgets. Currently, we are undergoing a lot of centralized negotiation and purchasing of technology. For example, vaccines are centrally purchased by the government, by the Ministry of Health, hepatitis C medication is currently centralized, purchased by the government, and probably it's going to move forward. We're working in payment by results mechanism throughout the system, not only from the government to HMOs, but from HMOs downstream, and have different schemes of solidarity contribution to have more resources in the supply side, as we saw. In the demand side, again, after the pandemic, we have higher social demands, a lot of unmet needs, and people that were not diagnosed or didn't continue treatment. So we have a lot of pressure from the demand side. There's prescription analysis on technologies and peer review of the technologies that are being used in a system such as ours that provides all the requirements for the people in the country. So we need to have ways in which we can define which technologies can be included in our benefit package and which technologies should be excluded from the benefit package. This is really, really important to have a sustainable system in the future. And in terms of management and control of the system, two ideas for this innovation side. One is there's a lot of uncertainty and current discussion for the next government on the role of these payers, on these HMO kinds of actors, on how they're going to work in the future and what's their role again in the system. Moving towards probably a general insurance systems with different finance mechanisms, but a more centralized coordination of the system. And on the second side, on the other side, Colombia has moved a lot on the digital transformation on the health system, and particularly on the reglamentación, that's a hard word in English, sorry about that, interoperable medical records, not having unified medical records for the system, but having a language of interoperability so that the more than 10,000 providers that are in the system can share data to better take care of their patients, quality of care, continuity of care in that sense. The health system is moving into electronic invoicing between all of the actors, and not because of the pandemic, but of course strengthened by the pandemic, the importance of telemedicine and telehealth as a central part of the system. All of them, again, as a major contributor to the innovation in the system. So that's, again, a very brief and high-level overview on the health system of Colombia. And I wanted to move really fast in the presentation to have some space, David, to have a discussion or specific questions regarding how the health system works in Colombia.
Thank you so much, Camilo. And I am here close to the people that may have some questions. I will start with one that was asked of me yesterday and I could not answer. Maybe you have the answer, not related to your presentation, but Professor Youssef was asking me about the availability of nurses and training excuse me, of nurses here in Colombia, if we had a surplus or if we had a need for nurses, Camilo.
Yeah, and it was in the presentation. I think it has two dimensions. One is the number of medical personnel, health personnel, and specifically nurses. As we showed in the presentation, the number is very deficient in Colombia. We have a higher number of medical doctors per 10,000 people than on nurses. and that makes a system really inefficient because a lot of care should be delivered by nurses in Colombia. So that's one dimension. The second dimension is the distribution of the medical personnel, of the health personnel, and most of it is concentrated on big cities. So when we move out of big cities such as Bogota, Medellin, Barranquilla, or Cali, the numbers are really scary sometimes. The numbers are really, really low, again, of all health personnel, but specifically on nurses. And then I'll include a third dimension, and it's the nurses' role within the health team. And the empowerment of the nurses' role within the health care provision needs a great revision. In Colombia, we don't have a role such as a nurse practitioner. We just have ancillary nurses and registered nurses. But again, we need to move forward in the empowerment on their role within a team, a health provision team.
Well, is it a 4-year degree?
Did you hear that, Camilo?
It's a 4-year degree for a nurse.
No, I cannot understand. Sorry. Again?
The training for a nurse is 4 years in university?
It's actually for a registered nurse. We call them jefes de enfermería. It's 5 years.
But for a doctor, medical school?
It's 6 years. So it's different from the states in which it's 6 or 7. There's one medical school in Colombia that's 7 years. The rest are 6 years. When you get out of high school, you go directly into medical school, and it's 6 years. So you don't have like college and then a graduate medical school. You go directly into medical school, and it's 6 years, 5 years of general training, and then an internship of 1 year. That's similar to the internship that in the States happens in the first year of residency.
That's interesting difference than in the United States, right? Because a nurse is a 4-year degree, or a CNA is 2.
Yeah, the auxiliary nurses are 2 years as well.
So 2 for testing. Anything from you, Yusuf? Question on the. Thank you so much. That was a wonderful presentation. Really enjoyed it. I took a bunch of notes. The discussion we had yesterday was around what does the company and your colleagues in the industry feel about innovation being sourced from outside of your traditional R&D in the United States or maybe major centers in Europe. I know that there are R&D facilities, for example, in China that have been set up to address specific things about that market. But what are your thoughts about innovation and design and development in places like Latin America?
That's a great question. I'll divide it into areas of research, development, and innovation. In terms of the production, for example, of medical devices, specifically the field in which Boston Scientific is in, Colombia has not been a big player both in research and development and production. There's not a lot of production plants within the country. Only, for example, Baxter has a plant in Colombia, and it's more on the pharma side and liquids and not on the medical devices. There's some medical devices being built in Colombia of local companies around orthopedics and low complexity medical devices. But for many reasons, Colombia has not been a big player in research, development, and production. However, in terms of software and exponential technologies or fourth revolution technologies and their use in the health system, Colombia specifically within Latin America has been shown around the past few years a high potential. Things like the development of AI platforms to support clinical decisions, blockchain, both in medical records and supply, the supply chain management applications. There's a lot of innovation in the use of these kinds of technology within the health system. So I think in the future, Colombia is going to be a big part of this transformation on the digital transformation of healthcare, and the quality of the engineers, programmers, and the cost efficiency of doing it from Colombia to other countries.
Thank you. Yeah, I would like to ask about like the one slide that there's so about like patient and the freedom of choice, and how do you think freedom of choice is performing Colombia in terms of asymmetric information, right? It's only about the payers, or also like about the elements that they buy or they consume?
That's an amazing question. And one thing is the freedom of choice around the construction of the system and the philosophy behind the system, and one thing is the freedom of choice in reality. So the freedom of choice in how the system was constructed meant that every citizen could choose between an HMO that builds a network of providers to better serve this patient. That meant that a citizen that will choose would have enough information to say, oh, this subsystem, EPS A, works better for me than this subsystem of this HMO. That's the logic and the idea behind the construction of the system. However, in reality, most of the citizens of the country would not have that information and would choose their HMO because of very different reasons. For working class citizens, are one of the main reasons is their employer's recommendation, and for subsidized population, most of the time it will be the HMO that actually works within the region or area in which they are living. So again, the idea behind it would mean that there's a lot of information available, that the citizens are empowered in terms of understanding the quality of the systems that each HMO manages. I think that's just a personal remark. I think that we can move forward in that sense, giving more and more information to the citizens, giving that freedom of choice, and using all of this digital transformation to make it really simple for each Colombian to choose their subsystem in their HMO. If any of the Colombians in the room wants to change their HMO today, they just go online to a system called SAT, Sistema de Afiliación Transaccional, and can change their EPS today. But most of us don't know about it. Having information available to the population is a big challenge.
Okay, thank you. And what do you think about like the most dangerous market failures in a local scale, like in Colombia, and how regulation improves the health system for every Colombian, right? And if you can provide like some use cases, it will be awesome.
Could you repeat the first part, the market what?
Market failures, like as a what do you think like right now are the most dangerous market failures in the healthcare system in Colombia? Like as we talked, like asymmetric information, probably oligopolies, natural monopolies, or what else? Like low supply scenarios. How regulation can be part as a solution.
That's the main point of the discussion of the new government on how these market failures, specifically on the HMOs that operate in specific regions, don't work. However, several years ago, a sub system started to take place through that's hard to translate. I'll say in Spanish about that. El modelo el MIAS, el modelo integral de atención en salud, and a policy that divided the country from the way in which the competency model works in big cities, and it's different from smaller rural areas. For example, today in Guainía, department, a state that's between the Orinoco and the Amazon, there's only one HMO and one provider for the whole state as a pilot project of that idea. Because there's a market failure when you have small populations with big areas and big land and low concentration of population. So I think that Colombia needs to move forward in scaling and those kinds of models that will be very different from the ones used in big cities around the country. That's a specific market failure. I think that we need to better understand the vertical integration between payers and providers, and how this works or not for patients, meaning better outcomes and higher efficiency or not. That's a big question that we have around the system that hasn't been answered. That's a second market failure. And again, I mentioned in the presentation, another area that it's going to be in terms of public policy scrutinized is the pharmaceutical policy for some technologies that have low oligopolies or even monopolies in terms of technology provision. So I think those three are big areas in which we need to better understand, have more information available to have twitches, nuts and bolts being turned and fixed that not necessarily mean to have a complete transformation of our health system as we know it today.
Okay. Just the last question about price. How do you regulate price control? It's like budget framed or more like a drug price framed. It's like a constraint in terms of like, do you have like this budget and you can do whatever you want with this, or you regulate the price of the drug itself?
All of them. Colombia has a very advanced price control policy in which the Ministry of Health, the Presidency, and the Ministry of Commerce participate. And it starts with the revision of markets and understanding how market economy works. It's different in pharma than in medical devices. Colombia has a commission that follows these markets. It's called la Comisión Nacional de Precios de Medicamentos y Dispositivos Médicos, and it has several instruments to address the market. The most extreme is price control, and there are several examples of direct price control of medical technology. For example, Colombia controls and has a maximum price for the medical stent, and there's a maximum price for the selling of the medical stent within the country. But it has other instruments, meaning surveillance of several technologies that they want to have a profound understanding on how the market works. And Colombia is also moving forward in not only direct price control, but other kinds of other ways in which it can have an impact on the pharma and medical device market, specifically having a value-based pricing for medical technology. This is being currently studied within the IETS, Instituto para la Evaluación de Tecnologías en Salud, and we'll see more on that probably in the next government.
Camilo, I have a question, and it's about the information of the healthcare system in the rural areas that are really far away. That information is taken into account on the data that you show us, or that information how is taken account in the healthcare system of Colombia?
Again, great question, and a lot of discussion on that currently in the new government. As a multinational company, we had during the past few years, or I had the opportunity to work with health information from several countries around Latin America, Ecuador, Argentina, Chile, Peru, Mexico. And when you do a comparison, it's amazing the kind of information we possess in several dimensions. On the provision of services, epidemiological information, several in financing. Colombian system has a lot of information. One of the weakest points of that, and I'll do a parallel with what we showed in terms of the mortality rate for 5-year-olds, is the profound difference between regions of the country. And when information needs to be either processed or kept locally, we have very different institutional capacities. So sometimes in specific municipalities or specific departments, the quality or availability of information is lower, of course, and we need to work together to improve that, because there are others that are being able to do it. We work closely with an organization called Así Vamos en Salud, an NGO and think tank on the Colombian health system that currently is understanding and building an index on rural health. And that's one of the areas that for sure can be improved.
Okay, Camilo, I want to thank you once again for your time, for the generosity of the information that you shared with us. Hopefully it is useful to our foreign visitors, and to some of us here is always something that we need to learn about the system here. So thank you again, Camilo, and we will see you soon. I would have asked you about the use of drones for healthcare, but I didn't have a chance. So we can
have a next discussion. my email was in the presentation, but David has my contact information. If any of you want to further discuss anything, I'll be available. Thank you again, and have a great meeting.
Thank you so much. Thank you so much. And with that, I welcome Natalia Valbuena, who is here with us. Natalia, thank you so much for being here. Apologies for the delay, but we had a good presentation from Camilo. Hopefully you heard some of that. Thanks for your time. We have some people connected to the Zoom. We have about 20 people here in the room. We asked you to come here and talk to us a little bit about the regulatory environment. In Colombia, we are talking about innovation, and surely the regulatory aspects are something that must be taken into account. So from your role in Medtronic, if you can tell us just a little bit about yourself and what you do on the regulatory environment here, that would be wonderful. So thank you very much, Natalia.
Thank you, David. Good afternoon to everyone. My name is Natalia Valbuena. Can you hear me well?
Yes, we can.
Perfect. Okay. I am pharmacist from the National University in Colombia. I have almost 30 years of experience in regulatory matters. I started with pharma products, vaccines, and now since 12 years, I have been working in Medtronic as a regulatory affairs director now in all Latin America countries. So the experience gained in Medtronic has been very important. And medical devices are very different environment that pharma and vaccines regulations. Talking about regulations, because medical devices is an very innovative industry, and it is moving so fast. For that reason, the regulation is also trying to be in the same alignment with the innovation speed. Sorry for I am a little bit with cough. Sorry. I will share my screen because I have only one slide. Are you able to see it?
Yes.
Okay. So I will do it in presentation mode. Okay. No, can you see it? But the presentation mode, or I don't know what is. No.
Yes. The microphone is over there.
Yeah, it was good.
It was good. Okay. It's because I don't know what is that I am presenting. Okay. Share. You can see the complete slide.
No.
We were able to see that before, Natalia. Before we were okay, now we're seeing the other screen. So
okay. So I will try again. No, I'm sorry for that. Okay. Now.
It's perfect.
Perfect.
Okay. The idea is to show you why it is important to have in account the regulatory matters. Because in the case of medical device, the people is inventing so fast or innovating so fast, and sometimes we forgot the regulation part. Why is important? It's because we need to to give full attention to the safety of the innovation we propose to the world. I will let you know a little bit about the history of food, drug, and device regulations starting in 1936. And this George Santayana is a philosopher and novelist, and he's telling us that those who will not learn the lesson of history are condemned to repeat it, and we don't want to repeat bad experiences that we have in the past. So in 1906 is the first like introduction of any regulation. The FDA published the act called Poor Food and Drug, that it was dedicated or focused on banning the sales of some narcotic drugs. At that moment, they are promoting narcotics for some specific indication, and we have, and it was some big problem at that time. And at the same time, Upton Sinclair's published the book The Jungle, and it was an experience of the environment or the employees packing meat packing process, and it was environment, meaning the people who works in that kind of process, the facilities used to do this process, and the quantity of illness or disease they transmit through this kind of process to the world. So it was very important for safety. In 1938, the FDA started to create the requirements for quality and identification of false claims, because they start to promote pharma products for indication that it was not related or it was no safety, like for example, elixir of sulfanilamida. This elixir caused massive poisoning to the entire people who use this antibacterial, use it as an antibacterial product. As another example, we have the bad experience we had with thalidomide in 1962, because it was used as a hypnotic in pregnant. So you know that it is a teratogenic component, and for that reason it's necessary to analyze the risk we have with each use of the medical device we promote. In 1976, Dalton Field is in an intrauterine device, the first medical device mentioned in the regulation that cause pelvic inflammatory disease and cause to the woman who use it an infertility. And it was big impact with the first medical device. In 1978, it was created the first time the quality controls through FDA. And in 1987, it was issued for the first time the ISO 90,000 standards. And here start the meaning of quality system regulation and requirements. In 1996, we start to hear from ISO 4085, sorry for my English. It was published, and it is the first regulation of system, quality system dedicated to medical devices. And also at that time, at the same time, was created the regulation in Europe for medical device. That means MDD and AIMDD. That means Medical Device Directive, Active Implants Medical Device Directive. This is the regulation that is applicable in Europe until 2018. In 2003, the regulation regarding the good manufacturing practice and quality system create an harmonization. The ISO 9001 was harmonized with ISO 13485, and then in 2016, the ISO 13485 was updated, and in 2018, UMDR, that it is the new regulation in Europe, was already implemented due to the implant of protease, the implants for mammalian implants that was that has a lot of impact in safety for women who has this kind of silicone implants, suffer some inflammations, and some of they develop cancer. It was necessary to create the stronger regulation for this medical device in Europe. For that reason, they create a new regulation in Europe. And this is the story of why it is necessary to have like a definition of a standard, safety standard, to design and to market new medical device. In Latin America, almost all of the countries are regulated. The most strict or the most critical regulation is Brazilian regulation, and then is Mexico, Peru, Colombia, Argentina. The only two countries not regulated are Panama and Chile. This is countries not regulated. We don't need sanitary registration to market products in those countries. Everything is, as I mentioned, controlled through a sanitary registration in each of the countries. We need to commercialize one product in Latin America. The idea of the regulatory agencies or ministries of health is to assess or evaluate the risk to the risk using that kind of new medical devices to the health of the people, of the population. And that's why it is necessary to have a regulation in the commercialization of medical device. I don't know if I went too fast, but this is why it is regulation important to have.
Thank you, Natalia. No, it is not too fast. I think this is something that for the most part, people are aware about the need, but not necessarily about the details. Perhaps one of the questions that I would have, Natalia, in your experience, is that our local regulator in Lima, in Colombia, is much more used to devices that are made abroad, but they don't seem to be prepared to deal with things that are developed here locally. And you probably don't have a sense from where you stand, because Medtronic brings, in your particular case, Medtronic brings things from abroad that are already made. But do you have an opinion about how INVIMA is prepared or not prepared to understand that we can innovate locally and they make it very difficult?
Why you mentioned that? Why you mentioned that they are not prepared to review the capabilities of our local manufacturers or innovators regarding medical devices? Because the regulation is already written. If you are an innovator here, you need to have first a certificate of the manufacturing plant, and it is called technical sanitary certification. And with that, having that, you can start to manufacturing the product. And if and in the other hand, you need to have proven safety for this kind of, for any kind of medical device that you design. So tell me why you tell me that INVIMA is not prepared for that.
Well, maybe it is because of the long time that it takes,
Yes.
the difficulty in talking to them and having, access to the people that maybe approve some of the local processes. We are wanting to tell the students at our universities and at our programs that they should become innovators, but then when they come with their products to bring to market, it seems to be difficult, maybe because we don't know how to do it correctly. Yeah.
The advice for that kind of projects or innovations, it is necessary to have the regulatory agency, in this case INVIMA, in our site. So the recommendation is having there, showing there how we are working with the new products or new ideas, why and how we are develop this kind of ideas, like bringing to them, to our facilities, and they know the process from the beginning, very beginning. That is the way we can have the regulatory agency from our side, showing them how we are analyzing and measure the risk, the possible risk we have in the design, in the manufacturing process, and that is the only way we can reduce the timelines, because I agree with you that the timelines are very big, long. Yes.
Questions here?
Well, I can speak about Peru and the local regulation group because I'm from there. And we had like recently some regulations about medical devices, like that started probably 4 years ago. It's very, very new. But the thing is that we actually have like in paper, like the ways that it's not prohibited that we can actually make innovations locally, but like somehow this is common knowledge that the regulatory agencies in Peru are more used to approve medical devices with the approval of FDA, because it makes like the pathway easier, like significantly. And the other thing is how can we prove safety and efficacy, right? Because if we have a medical device, it's not just that we have like the regulations, because I need to prove like safety and efficacy, and this is probably, it will be needed a clinical trial. So this is like, I think, the bottlenecks in the regulation that is not that well described.
Thank you for your question, and I agree with you. that in the case of Peru and all of the Latin American countries, if you have the approval from FDA or some big market like one country in Europe like UK or some country in Asia like Japan or some Australia or New Zealand country that it is huge, more regulated, give the regulatory agencies in Latin America more confident or trust in having or approve this kind of medical device, new medical device in our countries. It happens also in Colombia through INVIMA. If you have an approval from FDA or from Europe, it could be easier and faster to obtain the approval. Agree with that point. Yeah, and it is like a barrier we have in Colombia, for example, for new innovation or designing new medical device. Regarding the second question, it's how we prove safety and efficacy. First of all, I think the safety we can garantizarla. We can guarantee the safety with the materials we use. Materials like are already proven and the biocompatibility is already study approved and used through the times. And this is the first, the materials. The second, necessarily we need to analyze the risk of each design we have in order to start the medical devices clinical trials. First, you have to analyze the risk of the design. What risks have the design? Then the risk in manufacturing process. Then the risk in the human use. And that's it give you an idea or an pathway where you can design your clinical trial. In what risk you will design this study. It is the way. I know I don't know any other, but you have to have analyze the risks first.
Okay, thank you.
Anything from you guys?
Quick question. Thank you so much. Wonderful presentation. What's the average time and cost for an FDA approved cleared device to get approval in Latin American countries? And is there some sort of coordination between countries, or do you have to go country by country?
And you are asking me also for the time with FDA approvals?
No, once it's done and approved.
Once it's done. Okay. It depends in country by country, but for example, in Colombia, it is if you present an approval from FDA, you can have an approval in 6 months for medical device risk classification 2B or 3. The 6 to 8 months. For in Colombia, for medical devices that are risk 1 and 2A are automatically approved.
Class 1, class 2 automatically
approved. 1 and 2A.
2A, okay. What about the OVO or PMAs? Those take 6 to 8 months.
What about
What about PMA devices? Would that take 6 to 8 months?
pre-market PMA? PMA it is more than 6 months. 6 to some of them 1 year. It's possible to have 1 year in the evaluation process with INVIMA. In the case, and it is different in each country. For example, in Mexico now is taking long time, maybe 15 months for the approval. It is very delayed. In Argentina, you can have 6 months. In Brazil, 6 months. We have, as an average, 6 months for all Latin American countries.
Like it's a 1 year by pattern.
So there's no coordinated thing across Latin America?
No.
It's country by country.
It's country by country, yes.
And then what do the Chileans do? Do they just automatically allow you if you have a clearance to sell in Chile?
In Chile, there is no necessarily having sanitary registration approval. In Chile and Panama, you can import any product approved by FDA or Europe. You present the free sale certificate for the importation process, and that's all you need to sell any product in Chile.
Thank you. There is one more question. I think if you speak loud or in Spanish.
Just a little comment. In Viva may be slow, but they're very good. And for clinical trials, they know what they're doing, they just take a lot of time to evaluate it. And maybe because they're stuck with a lot of clinical trials going on, but we do a lot of clinical trials in Colombia for imported devices and also from here. And there is a very, very nice, like a spin-off law or new companies law in which you don't have to pay for sanitary registries for a lot of devices and food and the natural medicine that is available now. Let's hope the next government keeps it. You have to pay for all the big expenses of demonstrating safety and efficacy and all of that, but the sanitary registry in Vima is not charging new micro companies and entrepreneurships for these. So they are betting a lot on innovations. They're just very, very managing, they're very bad. And their website is a mess. And filing documents is difficult, but they're very good technically. And they are, I hope that they're promoting innovation with these laws. But the problem here, and as an entrepreneur in the medical industry in Colombia, is having the money to conduct those studies. The INVIMA is actually, and it's ridiculously cheap. Like they just charge you, I don't know, I'm gonna say $700 for revising your protocols for the clinical studies. That's something that in the FDA you cannot dream about. It's really, really cheap. And what they charge for that, what they cost a lot is the policy, the insurance policy, and the care during the study, etc., etc. But INVIMA's cost is really low, I think, so comparison with the USA. So
yes, agree.
In point of view, and I don't know if Natalia agrees, Colombia could be a really important country to perform these clinical studies. Like we have a very nice ecosystem to translate devices. We just need the investment to perform these studies, which is also why in the previous presentation, it was really absent the industry input into the system. But in the regulatory aspects to study and to innovate, I think it's well established.
Agree with you. Thank you.
Yeah, I think you can speak loudly now.
Okay, so let's say that we develop a novel medical device in Colombia. We the clinical results were like very positive, and we have the approval of BME in order to market the medical device here. But because investment was so long, probably our investors will need that device will be in other countries. So how will be the regulatory pathway in other countries with a Colombian approval?
It's a good question. Very good question, because Colombia has been recognized as a organized and structured regulatory agency in comparison with the other countries in Latin America because they are certified by PAHO in doing that. And yes, you are right. It could be useful to have an approval in Colombia to obtain registration in other countries like Brazil or Peru. Yes. But in how much in timelines? I don't know if Colombia is recognized as US. I don't think so. Maybe they will need to deep in the clinical part. I don't know if it is necessary also to present in those countries. Yes, definitely yes. You need to also present the same clinical studies that you present here in Colombia. There is not like a mutual recognition process for having approval already in Colombia. No, but you have to present the complete information that you present in Colombia to obtain the sanitary registration.
And it will be faster to, for example, if I have a Colombian approval, it will be faster if I want to market this medical device in Mexico to achieve an approval of inside medical device in Mexico, or an approval from Colombia in order to go into Mexico.
No, it's recognized that Colombia authority regulation, like INVIMA, has already grant an approval in Colombia, but this process will not guarantee or speed your registration process in Mexico. You have to follow the same process and everything, and it will not be faster evaluation. No.
Wouldn't it be better, smarter, Piero, just to get approval in the EU? And then you'll have,
EMA,
what's that?
in the EMA, like EU.
Yeah.
Europe
And then-
or FDA maybe can be more recognized than Colombia.
And then you'll have coverage, then everyone.
only 6
in
months.
Latin America will accept that in a few months. Okay.
That's actually the current way for this kind of medical devices for Latin America.
So you always start.
You start with FDA or EMA, and then you bring this medical device.
Yes, as a summary, having the approval in Colombia is good, but not enough to accelerate process in Mexico, for example, because it's more recognized approvals from EMEA countries or FDA in US. You have to follow the complete process.
So quick question, did I understand you correctly that most Latin American countries will recognize not only EU and FDA, but also like Australian regulatory approval or
Japan,
Japanese, and that would be enough.
Canadian.
Okay. Thank you.
It's kind of similar to the accelerated patent pay, in which you just submit the same papers and the studies are recognized.
Okay, all right. Natalia, gracias.
A ustedes, gracias. Mucho
Como
gusto.
siempre. Muy querida, y gracias por el idioma, que sé que es difícil, pero fue bien apreciado.
Gracias a ustedes, espero me hayan entendido.
He hopes you understood.
Gracias.
He hopes you understood what you said.
Yes, thank you.
Gracias,
Thank you.
Natalia.